Good morning. I'm Rowena Yip from Mount Sinai again. Today, my talk is on impact of time delays. I have no disclosure. So focusing on solid cancers, which is usually the most aggressive ones, protocol generally provides three main options for workup based on size. If the nodule is very large, solid nodules, as the probability of malignancy is so high that we usually send these nodules immediately hit for intervention. If the nodule is so small, we're comfortable that their probability of malignancy is so low that we'll recommend annual follow-up. So a lot of times that leaves us with the intermediate size nodules, which is usually between 4 millimeter to 20 millimeter. Management of these nodules focus on gaining additional information about the probability of malignancy. So here are, the probability of malignancy for these nodules can be obtained in various ways, but the dominant approach is to estimate whether the nodule is growing at a malignant rate. Here shows some of the management protocols for solid nodules seen on baseline in different countries. We can see that protocols differ as to size threshold and follow-up time for these nodules, but recommendation typically is 6 months, 3 to 6 month follow-up CT scans. So according to us, the weakness of these protocol is that we don't know what's the change of prognosis or cure rate if we wait for 6 months, for example. Empirical data for determining the optimal schedule for these, how to follow up these nodules is not there, and protocols primarily determined by consensus opinions. So the optimal time interval for obtaining follow-up diagnostic scans depends on nodule management, nodule measurement accuracy. The greater accuracy, the shorter the follow-up time to confidently measure growth. If there's no harm in waiting, there's a longer follow-up time would always be better. So there's always a balance between accuracy of growth measurement and decreasing prognosis. Previous research has looked at the impact of delays in the context of treatment. A recent meta-analysis found that it could not be quantified because of the heterogeneity and methodological flaws. In a large individual study in the US using the National Cancer Database, the study reported 3.2% increase in mortality per week of delay. And the impact was greater for early stage than late stage cancers. And similar trends has been reported in the national cohort study from Taiwan. So the purpose of this talk is to summarize what we have published in the past 1 or 2 years. We look at how diagnostic delays in follow-up imaging affects survival outcomes in patients with early stage lung cancer using 3 different large databases. First, we published on using the I-ELCAP database, and then we have another publication on using the NLST and the IASLC staging projects data. So in this study for I-ELCAP, our goal is to quantify the change in lung cancer cure rate due to delays for follow-up scans in order to assess growth using data from 2003 to 2019. Here on the left, the figure on the left shows the cure rate based on the plateau of a long-term follow-up, long-term lung cancer specific survival. The cure rate was 84% among patients diagnosed with solid non-small cell lung cancer on baseline in I-ELCAP. On the right, we further stratify it by the cure rate by size categories, and we saw that the cure rate decreases with increasing nodule size. So with those information, we're able to fit a regression model to estimate the change in cure rate for different nodule size, initial tumor size. In this first order consideration, we base our estimation of the lung cancer cure rate on an assumption that lung cancer would remain in clinical stage 1 during the follow-up period. So next, we estimate the change in tumor size after the delay of 3 months, 6 months, and 1 year, using representative of different doubling times of fast-growing nodules of 60 VDT of 60 days, moderate growing nodules of 120 days, and doubling time of 240 days for slow-growing nodule. And then we examine the impact of delaying in the diagnostic workup based on these changes in size. So this is a kind of busy table, but this table will provide the change in average tumor diameter for fast, moderate, and slow-growing cancers according to the initial nodules. Initial nodule size here, and S stands for slow-growing, intermediate, and fast-growing nodule. So for slow-growing 4 mm nodule, here, we can see that it will increase to 4.4 millimeter after 3 months, 4.8 millimeters after 6 months, and 5.7 millimeters for 1 year. And for slow growing 20 millimeter nodules, after 3 months wait, it will grow to 21.8, 6 months, 23.8, and 1 year, 28.4. So the absolute increase in size is always greater for larger nodule. And for a given following doubling time and time of follow-up, the ability to measure true change is easier for larger nodule. So in this same table, we can see that for a small nodule less than 6 millimeter, that I bracket in red, for slow-growing lung cancers, we would not be able to measure true change for less than 1 year. But if it's a fast-growing nodule, oops, sorry, we can. So this table shows, sorry. So this table shows the estimated, it's not, this table shows the estimated absolute decrease in lung cancer cure rate for different initial diameters and 3 different delays in the diagnostic workup separately for slow growing, intermediate, and fast growing nodules. Let me go back. Sorry. And we can see that the impact of time delay increases with increasing size. So here is just a graphical illustration of how the cure rate will change with different initial size. On the x-axis here is the initial size of the tumor, and the y-axis is the estimated lung cancer survival, and the z-axis is the number of days of follow-up. So we can see that for this fast-growing nodule, if we're looking at the 4 millimeter initial size, it has a pretty high 95 or 97 lung cancer specific survival. As we increase in duration of follow-up here, it still remain pretty high in the 80 to 90% range. So, but then if the nodule is much larger in the 20 millimeter range, the initial size is somewhere around 80%. And then if the follow-up delay is much longer, it can get to very low in the 10% or 20% range. And this is for moderate growing nodules and then slow growing nodules. So the second part is that after we got the I-ELCAP result, we also want to validate our published findings using the same methods, but applying on the NLSD and ISLC dataset. And we published this last year, and along with the publication, there was an editorial. So in this paper, we used the NLSC CT arm data of resected clinical stage 1 lung cancer less than 30 millimeter. That's about less than 200 cases, there were 26 lung cancer deaths. And the site-specific 10-year survival, lung cancer-specific survival, was the surrogate for cure rate here. And separately, for the ISLC staging projects, we selected data from 2011 to 2019 and included over 22,000 clinical stage 1 cases. And here, because the paper only reported on 5-year overall survival rate, so that was the surrogate for cure rates here. So what we found on using these two large databases was that although the average tumor size was larger in NLST and ISLC staging database, the average change in lung cancer cure rate per unit increase in tumor size was comparable to what we found using the I-ELCAP database. And these findings support our early research indicating that the interval between scans required to evaluate the growth of lung nodules has a significant impact on prognosis, particularly for fast-growing and larger cancers. There are some limitations. Our prognosis was only based on tumor size, so but other prognostic factors could exist, and we did not account for that in our model. This is our first step of developing a very simple model just to estimate the change in cure rate. And we also know that as nodule increase in size, there's a higher probability that it will metastasize. And then but for that, we assume that these nodules remain in clinical stage 1, and it may underestimate the impact of delayed diagnosis. Again, and the ISLC only reported 5-year survival, and that was what we used. And also, lastly, is that we used the analysis used the change in diameter and not volume here, but we don't expect the conclusion is going to change much. So in conclusion, timely follow-up is crucial for management of lung nodules. Impact of time delay is greater for larger nodules, although the impact of measurement error is less. Benefits of any biomarker tests or imaging biomarkers needs to balance the added benefits of early diagnosis against the potential increase in false positive and false negative diagnosis. The ability to predict whether a nodule represents a fast or slow-growing cancer should become a priority in protocol development. Lastly, delays in CT scans have a significant impact on prognosis, and quantifying these delays impact can inform better management protocols. Thank you. And I'm leaving you with a quote from the editorial.
For question. Still, we have a minute. Is there a question? Open question, please.
I recently did an editorial review in which the authors decried the risk of delay for growth measurement and suggested use of molecular screening as a way to avoid that risk. And you just mentioned that. Is there any other information on that question?
So you mean liquid biopsy, including liquid biopsy, because it's the CT diagnosis, right? It's the interval between CT diagnosis and resection, right? This is the interval you're after, right? And typically we only have imaging, right? And you could sort of do a blood test, which is not part of the screening at the moment. So yeah, exactly. That's why I think the information is not there. Maybe that's would be an answer. My question to you would be, what's the average time from CT to resection in your hospital?
We have looked into that. I think it was around 1 month, if I remember correctly.
Yeah, thank you. In Germany, due to the healthcare system, it's a little bit longer, and we're going to but on average, and we have we monitored that in the Hansa study, and there's variability in this, depending on second opinions, workflow, and sites. There's difference between sites. And I think you make a very important point. We need to harmonize, and foremost of all, we need to monitor this, right? It can be easily monitored, right? All right.
Can I make a comment?
Yeah.
So just a very quick comment. The big problem with this is that if you speed up the process, as I've seen, for example, in Spain, we're establishing pulmonary clinics led by thoracic surgeons, and the rate of false positives goes way up. So you quickly start operating on benign nodules because we depend on that growth to determine who goes to surgery. So it's a big concern. I understand, and it's a catch-22. What should we do? Should we focus on not missing these tumors and operating on them earlier at the expense of false positives, or wait that 3-month period or 6-month period?